Hello, I'm Dr. Craig Childress here, running through my Vita. In this segment, I'm going to be talking about the aftercare program at UCLA on schizophrenia. It's a longitudinal clinical research project on schizophrenia. Principal investigator with Keith Nectarline. I learned gangbusters in that experience. And so I graduated master's program. It's non-terminal, doesn't give me a therapy degree. I got a job at UCLA. My culture, I was an undergraduate at UCLA, clinical research project, longitudinal. And it was a very good project. When I joined, it was somewhat small. Their offices were in Westwood Village, in the suite of offices. When I left, it was really powerful. About 5, 6 years into that, Harvard started to recruit Keith Nectarline to join them at Harvard. And UCLA became anxious about that, and UCLA was building a suite of 3 buildings. The medical complex is right across from the medical center, so 3 new medical center buildings. And in order to keep Keith Nectarline at UCLA, they gave him an entire floor of the new medical offices, 300 University Way or something, 300 office buildings, and they gave him an entire floor was the Aftercare Clinic and Keith Nectarline to keep him there. So it was a big project. The battery of testing we do, I was hired as a tester, so I was hired to come in and administer the test measures. Then, because I stayed there, the people who hired me and trained me in testing, they left, and I kind of rose up in the testing category, and I began to supervise all aspects of data management for this complex, multifaceted, multi-site research study. And it had all sorts of data, physiological data, GSR skin responses, smooth pursuit eye tracking. It had interview measures like the WISC, intelligence measure kind of stuff, symptom rating measures. It had MMPI type stuff, paper and pencil. It had all different types of measures, observational measures, all different types of measures from multiple sites and everybody, and coordinating all that. It was a longitudinal project, so we would we would identify the schizophrenic patient while they were in the hospital. It was the first break. It was a criteria. This was the first episode of psychosis that this person displayed. So we had one person, Rosemary, who would just go around the local hospitals, UCLA, Harbor, Metro, and she would just screen patients. She would just sit in the chair and just screen patients to see if if any patients were close to meeting schizophrenia diagnosis. If she located someone, the first episode, young person, maybe 17 to 22, first episode of schizophrenia, she would begin the process of information gathering about their symptoms and potentially recruiting them to join our research project. And we would have staff meetings where we would discuss the symptoms of people, whether they were schizophrenic or schizoaffective. Schizoaffective mainly affective, schizophrenic mainly schizophrenic. This is back DSM-3 days. I think they've gotten rid of the schizoaffective diagnosis. But it was like, or bipolar disorder with psychotic features. And so there was very interesting diagnostic discussions as part of that team. And so I joined as a tester. I started moving up the ranks. By the time I was done, I had like 3 people I was supervising doing the testing, and I was kind of managing the information flow systems, managing the JADE flow systems. Now, while there, one of the things we did was symptom management, symptom ratings, because we would do testing when they joined. That would be the inpatient testing. Then when we stabilized them and their symptoms went away, they would be in remission. So we would do another test battery at that point. If they had an exacerbation, defined as a 2-point rise on the BPRS, we would do another testing. They had an exacerbation of the symptom. If they had a relapse, which is a 6 or a 7 on any of the psychotic scales, then we would do another test. And then we do it at the 1-year point, and then we had double-blind crossover trials. And so that would go on for about 3 years was the protocol. And then when they finished the 3-year protocol, we wouldn't kick the patient out. If the patient needed us, we would still stay there forever and ever for them, but we would allow them to transfer elsewhere. Would not allow them, but if they wanted to transfer other places, we weren't upset with that after the 3-year point, but we would never leave a patient. We had a moral, ethical responsibility for these patients. We work with them as long as they wanted to work with us. So, but for the most part, the research protocol was for 3 years, 4 or 5-ish. So one of the aspects of that, though, is we monitored their symptoms to note remission, exacerbation, relapse. And so every 2 weeks we would do this particular symptom rating scale called the BPRS, the Brief Psychiatric Rating Scale. Started out as 18-item, grew to 24-item rating scale. Rates all sorts of symptoms: depression, anxiety, suspiciousness, bizarre behavior, grooming, personal care, as well as psychotic symptoms, hallucinations, conceptual disorganizations, and unusual thought content, delusions. Those are the 3 psychotic scales: hallucinations, conceptual disorganization, and delusions. And it's a 7-point rating scale. So 1 is no symptoms present, 7 exceedingly high symptoms. The cutoff between normal range and pathological range is between the 3 and the 4. Okay, so 1, 2, 3 is normal range on the symptom. 4, 5, 6, and 7 are the pathology range of the symptom. And because these were such crucial symptoms, and this is a good research project, and this is what we do, is we get inter-rater reliability. So all the case managers, about 4 case managers, and myself, all are trained to reliability on the BPRS, on the symptom rating scale, so that we all rate all symptoms the same way. And the way we're trained to reliability is that every year we would go through reliability training with the diagnostic unit. Now, the diagnostic unit was located over at the VA under Bob Liberman. Bob Liberman was the head god of this kind of stuff. He worked UCLA and the VA. And so the VA, because Bob Liberman was over there, contained certain functions that UCLA would also collaborate and use. So the diagnostic unit was over there, and the data management, the statistics people were over there, Jim Mintz. And so the diagnostic unit was located over there, but had strong ties into the UCLA Aftercare Clinic. The head of the diagnostic unit was one of our case managers, one of our researchers, Joe Ventura, Michael Green as well. So every year, the diagnostic unit, Michael Green and Joe Ventura, would, during the course of the year, film some of their interviews with patients, and they would be the gold standard for the rating. And they would select 10 of these patient interviews, and we'd have to watch them on videotape and rate the 24 symptoms of the patient, and we had to get like 90% agreement with Joe Ventura and Michael Green, the gold standard, on these interviews, which means we had to pretty much hit every rating accurately. Of when they rated a 5, we got to rate it a 5. When they rated a 7, we're rating it a 7. 3 is a 3. Now, we can have some fluctuations. They rated a 5 and we go 4. Okay, there's a little bit off there, and so it's not precise. That's why it's a 90% accuracy. But we can't be getting, if they rated a 5, we can't rate it a 3. And it's going to like dink our reliability numbers if we're off by that much. Or if we're off, they're rating, and if we're always 1 off, that's going to hurt our reliability ratings. And if we don't reach reliability on that round of 10 videotapes, we have to do another 10 videotapes. We get additional training and do another 10. So we don't want to go into that additional 10 training. So we learn how to rate. And the BPRS is really well structured. 7 points, anchored points, really good, really solid. So you learn what the anchor points are. You learn how to apply them. Okay, that's what we do, inter-rater reliability on the BPRS. Now, one of the reasons I explain this is because this has implications for attachment-related pathology surrounding divorce. Because attachment-related pathology involves a delusional belief. It involves an encapsulated persecutory delusion. And I know what an encapsulated persecutory delusion looks like. There's not a whole bunch of psychologists out there who do that. The ones who work maybe schizophrenia, bipolar disorder, they work psychosis, so they know what a delusion looks like, what an encapsulated delusion looks like, what a persecutory delusion looks like versus a delusion of reference versus erotomanic delusion. They know, and especially working UCLA on a major research project, doing these symptom ratings, reliability on the BPRS, I know what delusions look like, and I know all the varieties of delusions, and I know their rating on a 7-point scale. I know the difference between a 4 and a 5. I know the difference between a 5 and a 6. I know the difference between a 3 and a 4. I know what qualities I'm looking for and what factors determine severity. That's an unusual knowledge set for a clinical psychologist. There's a limited knowledge set. Not a whole lot of people have that sophistication in delusions or hallucinations, conceptual disorganization. Conceptual disorganization also plays a role in ABPA. That knowledge base about delusions is extraordinarily rare in child and family therapists. Child and family therapists almost never see psychotic disorders. Psychotic disorders are adult disorders. You don't see childhood psychosis very much. It's autism spectrum, but that's autism. That's not psychotic. It's very rare to see childhood psychosis. And so child and family therapists spend most of their time training in child and family therapists or doing they know ADHD, they know oppositional defiant, they know behavior programs, they know all that kind of stuff. They don't know delusions. That's not their specialty. It is mine. I got that background. And so that's going to become relevant as we talk about the diagnostic indicator 3 of the delusional belief system. So follow me over to the next one. I'll continue to talk a little bit about this aftercare period.